Hey lovies, how are y'all doing today? Hopefully you're having a wonderful day. I wanted to jump on and give an update about my thyroid. I did two preliminary videos. I wanted to make it a series, but I kind of got carried away and went off on its own. But I'll try and bring it back together, maybe put them together as a series, where initially I talked about just medical care and self-advocacy, making sure that you're speaking up for yourself when you're going to see your doctor and you have questions, making sure you're speaking up and asking the questions that you want to have addressed. And then the second video, I just talked about my thyroid nodules, explaining the background of my nodules, which I've had for quite some time. It's been well over, I want to say 12 to 15 years, just monitoring because I did have a small goiter. My thyroid was enlarged a little before. It never was to the point where it was so large that it was noticeable and you could just see it, just at a glance. But if you feel and knew what you're feeling for, then you could feel where the inflammation was in my thyroid. And so over time, we've been watching, monitoring, making sure my levels are, making sure my levels are not too high or low and staying within range, and they have been. Also making sure that the nodules that were later identified in my thyroid were not growing, and they had not been growing significantly. Any growth that happened was over the course of years and very minimal. So those are the things that I was talking about before. And then I believe in the second video, I talked about my biopsy, where I went to see one of the endocrinologists, and she decided that she wanted to go ahead and biopsy the thyroid nodule that's on my isthmus, which is the center portion of the thyroid that sits right over the trachea or your windpipe. And so we decided, yes, we would go ahead and biopsy it, simply because it had grown a little bit. It still was not quite within the recommendation range for biopsy because it was small, but due to the radiological coding of the nodule, we decided to go ahead and biopsy. And when I say the radiological coding, there's a TIRADS table that they use, T1 to T5, I believe it is. And let me look so I can be a little bit more informational as I'm telling you guys about this. But it's TIRADS. And what they do is they look at the characteristics of the nodules that are in your thyroid. They'll look at things like calcification, the border, and if it's a smooth border versus if it's rigid. They will look at the width versus the height of the nodule. So there are quite a few characteristics that go into rating those nodules after you have an ultrasound to see how the radiologist would rate them. And it just tells you if they feel that those nodules would be suspicious for any cancer or not. And then that way the endocrinologist can decide whether or not they want to go ahead and biopsy the nodule depending on the size. And now normally if the nodule's below 1 centimeter, there is no recommendation to biopsy because that's considered extremely small. So it's not until they reach, well, it was 1 centimeter, and now I think it's moved to 1.5 because the doctor that the intern that I spoke with last said that usually if they're not 1.5, they wouldn't recommend either unless there were some series considerations. So the TIRADS looks at the composition of the nodule. So it looks at if it's cystic or spongy form, or if it's solid. And then it looks at the echogenicity, which it looks to see if it's hypoechoic, isoechoic, or hyperechoic. And then that just tells them how it looks against the radiological scan. And again, it looks at the shape, which I did mention in the margins, whether it's smooth around the margins or if there is any rigidity there. And did I miss anything? There's something called echogenic foci, which is the microcalcification that I spoke about, and they're more associated with the papillary thyroid carcinomas, which is the most common type of thyroid cancer, which is the papillary thyroid carcinoma. Okay, so with all of that said, I did have a nodule on my isthmus that was rated at T4, and T4 is moderately suspicious for any type of thyroid cancer. So the first rating is T1, which is 0% risk of malignancy. Then there's T2, which says it's not suspicious at all, but they'll follow up depending on the size of the nodules. T3 is mildly suspicious, T4 moderate, and T5 is highly suspicious. And then they'll also give you like percentages of the malignancy risk depending on those TIRAD ratings. All right, so that's all about the TIRAD. So once we looked at my nodules again during my last endocrinology visit, which I want to say was May, we decided, okay, we'll go ahead and we will biopsy to see what's going on. If there's anything going on, it will be an early catch, and if not, we'll just continue to monitor. And we did our biopsy, and then I got my results for the biopsy earlier this month, which was mid-July. And the biopsy results were positive for papillary thyroid carcinoma. So papillary thyroid carcinoma, again, is one of the most common thyroid cancers that there is. And when they remeasured the nodule, it was 1.3 centimeters. So there was a little bit of increased size. Not sure if it was from swelling from the biopsy, because when we did the biopsy, there were there were 5 passes. So when they did the biopsy, she went in and she did 5 needle passes to pull samples for the cytologist who was there on site during the biopsy, because he was there to make sure that each pass was good and clear enough that they could get a good read on it. And then they wanted to also send one out for labs to get a confirmation. So that was that. Give me one moment. All right. So as I was saying, yeah, the endocrinologist did 5 passes and 1 cell block, which is what it's called, from the 5 passes, and sent it out to cytology. And well, not sent it out. Cytology was there to look at it. Of course, they didn't give me the results at that time, but he was there monitoring each of those samples as she was pulling them. And then they, of course, sent one out to lab for verification as well. So after that, after the test results, after she provided me the test results, which was probably maybe a week later, the next week, she called with the results and scheduled me for ENT surgery consult visit to see what we wanted to do after the finding. So I went to meet with ENT, and I'd already done a lot of research, so I kind of knew what my options were going to be, but I'm not sure if there was anything that was more recent in the literature that I wasn't aware of that they might recommend. So after my visit, first option is an isthmusectomy, which is where they would just take out the center portion of the thyroid, leaving the two lobes intact and hopefully not causing the need for hormone replacement therapy. The second option would be a complete thyroidectomy, which would be to remove the entire thyroid, which I don't see the need in doing that, except that if the other nodules had a higher risk of being cancerous. And I'll talk about that a little bit later, the other nodules. And then there was the option for radiofrequency ablation, which is where they will send you to an endocrinologist who specializes in radiofrequency and will use that method opposed to surgery to attack the cancerous cells. And then, of course, the other option, which is watching weight. And that was at the top of my list initially because I was under the presumption that because my nodule was so small and it was so slow growing, and then with papillary carcinoma being a common cancer that is known to be slow moving, we could watch and wait. And if it didn't, increase my symptomology, or there was no reason to fear that it would grow outside of the thyroid gland or infiltrate any tissue surrounding the thyroid gland, that I could just pretend that it was just my new little friend. But because of the location of it on my isthmus, which sits right on the trachea, which can push against the windpipe, interfere with breathing, and also with the vocal cords, they did not recommend the watching weight. So with that being said, watching weight is off the table. Radiofrequency ablation is also off the table because that's really usually reserved for folks who cannot, for whatever reason, have surgery. And also looking at some studies, I was reading that there is a potential increased risk for leukemia in some patients who choose to have radiofrequency ablation. So that really kind of turned me off from that option, because that would have been my second option, if not for the high risk for leukemia being involved. So there we go back, and it takes me back to the isthmusectomy. So I will go probably within the next week. I'm waiting for a follow-up appointment for my pre-op consult with the doctor and the intern. One moment, they're calling me now. All right, and so that was the intern calling to give me some more information, actually, because I talked with him earlier today, and I asked him about who was actually going to be the attending physician for the surgery, because I wanted to know who it was and what their experience was as far as doing the isthmectomy versus thyroidectomy. And he was telling me that the removal of the isthmus is much easier than removing any of the lobes, because with the lobes you have the parathyroid glands and you have the nerves that relate to your vocals that the surgeons have to be more meticulous about avoiding and working around, whereas the isthmus just covers the trachea. So that was reassuring, but I had some other questions. So he was calling me to let me know that he did talk with the attending physician, and my other option would be go over to UF Medical if I did not have the surgery under her. And then, of course, he was acknowledging that they may even suggest a complete thyroidectomy, which that is not an option for me unless there was, some health concern or reason that they could show me that would constitute really removing my entire thyroid, because that would be, as he stated, overkill. So that's where we are. I will have my consult soon, and I will probably ask a few more questions before I set a date for whatever procedure it is that we decide on definitively, which will most likely be removal of the isthmus portion, so that I can maintain my thyroid function, not have to take meds long term, and not really be impacted, because of course I don't want to have surgery at all, but if I must, I want to do what is going to be minimally invasive and not have long-term impact on me, because I am almost 50, so that means I am approaching a stage of hormonal fluctuation. Anyway, so I'll be entering menopause at some point, and so that is also a change in hormones. So as much as I can maintain my thyroid function at this stage in life, I'm going to do that. But I will keep you all informed on how things go, and I'll come back and do a video update once I have my pre-op consult and make some more decisions, get some more information. Excuse me. And we'll go from there. Yep. So that's all I have for you today. Hopefully this information is helpful for some of you. If any of you have had a thyroid goiter or have had thyroid nodules, and just wondering what they are, where they come from, and nobody really knows where they come from. A lot of the literature I read say it's a lot of environmental exposure that can cause the thyroid nodules. Now, I don't know how much exposure and what exposures exactly. Usually, I'm paramilitary, so my MOS was chemical operations. So we've been exposed to a lot of things, but in our day-to-day environmental as well, we're continually exposed to all sorts of stuff. So we don't know what exactly it is that causes the things that happens in our life, but as much as we can figure it out and find out, we can be proactive in trying to prevent exposure to certain things for ourselves and our loved ones in the future, so that we can avoid these conversations and avoid these things from happening. We can still have a conversation because information is powerful. So hopefully this helped you. And if you know anybody going through anything with their thyroid or nodules or even papillary thyroid cancer that might be interested, please share this video with them, and hopefully they can learn something as well. All right, I love you guys, and I'll chat with you later. Until next time, stay grounded and stay centered. Love y'all.